Hello everyone, very good evening to all of you and welcome to the my YouTube channel. And today I'm going to discuss another episode of the pathology where we are going to discuss important MCQs which we are going to have in our FMGE exam. So this is the part 2. This is the miscellaneous topic, Rahul. Very good evening, HK. Hello, Udit Karmakar. I hope I am audible and visible to all of you. Yes. Good evening, Rahul. Good evening. So let's start, and I will be taking out the name who is giving me the first correct answer, right? So let's start the question number 1. This question was previous year question also. A patient was planned for the transplantation. A patient was planned for the transplantation. Now he has a twin brother who is matched donor for him. So his twin brother is matched donor for him. So what kind of graft it is? Isograft, allograft, autograft, or xenograft? So what should be right answer for this question? Twin brother, isograft, allograft, autograft, or xenograft? So what is your answer here? Okay. So this is a isograft, right? So same brother, right? Same twins. If you are getting the transplantation from the twin, I think who has given me the correct answer? Uh, First correct answer is given by Roku, Pragya, and Rahul. So these are the three people who have given me the first correct answer. It will be isograft, right? So please remember this question is a simple question and your answer should be isograft, right? So between the twins, isograft will be happening. So now you can see this is a very simple diagram which will help you to remember or memorize types of the transplant, right? So first is isograft. So isograft is between the identical twins. Now you can see isograft is between identical twins. So both are looking same color, so they are twins, right? So between the twins, isograft. Clear hai? Between the twins, isograft. Autograft means self, right? Some area from his own body has been implanted on some other area of the body, so that is called as autograft. So this is autograft. Allograft means, see, these are two different colors, right? So one is purple, one is pink color. So that shows that this is the same species of the human being, but they're different individual, they're not from the same family. So this will be the example of allograft, right? And when we are planting, right, when we are taking from the different species, then you are going to call this as xenograft, right? Now this individual is getting xenograft from this pig, right? So that is one example I have kept it here, right? So that is called xenograft. So please remember here, autograft means from ourself, right? So this is autograft from our own self, right? Syngeneic, remember, syngeneic or isograft is for identical twins. So this was the question, right? Isograft or syngenic graft. So examiner can use this name also, right? Isograph or syngenic graft. This is so both are looking same. So these are the twins, right? So among the twins, isograft or syngenic graft, and on our self body, that is called autograft. Allograft means within the same species. Remember, non-identical individual. So now you can see they are not identical, right? They are not identical. You can see their color is not identical, right? So this is the color coding which I have kept here. So non-identical individual of the same species. Both are human, but they are having different thing, right? Different color. So these are the allograft, right? Xenograft is from different species, right? So this is the pig and this is the human being. So I hope you all understood this point. Isograft, autograft, allograft, xenograft, right? So very important point which examiner can ask you question again, right? So let's move on to the next question. Next question is a 55-year-old male is having chronic renal failure and he was on hemodialysis from past 7 years. Hemodialysis from past 7 years. Which of the following amyloid deposit will be expected in this patient? So tell me, what should be correct answer? What should be correct answer? Non-identical means not the same family, not from the same family means not the twins. Identical means twin. Who is our identical? Identity will be shared by the twin. Okay, Nikhil, did you understand? Nikhil, identical means twin. Non-identical means not twin, not from his family, right? So I have got first correct answer. D. Who is this? Sri Nandan Dikshit. So Sri Nandan Dikshit and Prabhu Manyam Gopi and Switi Sharma D. Okay, Switi Sharma is not C, it's D. Right. So your answer should be D. See, this is the very clear-cut history and very beautiful picture of the, patient. You can see a 55-year-old patient having chronic renal failure, and he was on hemodialysis from past 7 years. So what is associated with hemodialysis? The AA type is a secondary amyloid, right? AA type is a secondary amyloidosis, and it is associated with chronic inflammation. Clear? Mutant ATTR is the different kind, and this is associated with familial amyloid polyneuropathy, right? So familial amyloid polyneuropathy is associated with mutant transthyretin. A is amyloid, TTR is transthyretin, right? A beta is a localized type of amyloidosis, which we are going to see in Alzheimer's disease, right? This will be seen in Alzheimer's disease, and this is the correct answer. A beta 2 microglobulin will be seen in hemodialysis associated amyloidosis. So please remember, hemodialysis associated amyloidosis. And what will be the characteristic feature? These patients, they may come with the compression of the median nerve and carpal tunnel syndrome, right? So they may come with the carpal tunnel syndrome, because this deposition, this A beta 2 microglobulin deposition will be usually seen in the synovium, tendon, right? So all these areas. So when they will be involving synovium of the hand compartments, median nerve will be compressed and they will be having atrophy, and that will be leading to the carpal tunnel syndrome, right? So now you understand. So examiner can ask you question like this: a hemodialysis patient came to the orthopedics OPD with carpal tunnel syndrome. With carpal tunnel syndrome, then you have to remember this is because of deposition, and after deposition this will be causing pressure atrophy of the median nerve, right? So this is the pressure atrophy of the median nerve, which will be the reason. So now you have to apply this knowledge, right? See, the pathology is not only the solving MCQ. Whatever you are solving, you should apply that as a clinic also. In a clinic, you are sitting and a patient is coming with a euro bag, and you have to ask the history of the hemodialysis, and this fellow is telling the long term of the hemodialysis, and he is coming with the carpal tunnel syndrome. So think about A beta 2 microglobulin amyloidosis, which is a hemodialysis associated amyloidosis, right? So here I will be telling you about important point about the amyloidosis. So systemic and localized amyloidosis we can divide in systemic and localized. Systemic amyloidosis can be of 4 types, right? As you can see in this picture: primary amyloidosis, secondary amyloidosis, hemodialysis, and heredofamilial, right? Primary amyloidosis. So I'll brief you because many questions are framed from here. Primary amyloidosis will be AL type. Can you tell me what is the L? Anybody? Can you tell me what is the L here? L stands for light chain of immunoglobulin. L stands for light chain of immunoglobulin, right? So where you are going to see the primary amyloidosis will be seen in the plasma cell disorders. So this will be seen in plasma cell disorders, for example multiple myeloma, right? For example multiple myeloma, right? So this is the light chain of immunoglobulin. So remember, AL, only one A is coming, so this will be called as primary amyloidosis. When you are seeing amyloid associated protein, this is called secondary amyloidosis, right? And secondary amyloidosis, you have to be very careful because this is a dangerous question. Secondary amyloidosis is seen in chronic inflammation. Can you tell me which chronic inflammation is most commonly associated with secondary amyloidosis? That was the question. Can you tell me which is the most common cause of the secondary amyloidosis? Which chronic inflammation? TB or bronchiectasis or rheumatoid arthritis or osteomyelitis? Yes, very good. Mahesh is telling me the first correct answer. Rheumatoid arthritis. Very good, Mahesh. Well done. Right. So this is the most commonly associated with rheumatoid arthritis. Right. This is most commonly associated with rheumatoid arthritis. Right. So secondary is most commonly which chronic inflammation? Rheumatoid arthritis. Here what I want to tell you that secondary amyloidosis can be a part of paraneoplastic syndrome also. Not only the chronic inflammation, part of paraneoplastic syndrome. So you have to be very careful because this question had been already asked. If examiner asks you renal cell carcinoma, please do not get confused with the kidney, because many students they get the kidney and they think only hemodialysis. Don't think like that. Read question very carefully. Renal cell carcinoma. So renal cell carcinoma, we are going to see paraneoplastic syndrome, Hodgkin's lymphoma, paraneoplastic syndrome, and which type of amyloidosis? Here you are going to see AA type of amyloidosis. So please remember renal cell carcinoma AA type. But when you are seeing a history of hemodialysis, right? When you are seeing a history of hemodialysis, that time you have to remember it will be having A beta 2 microglobulin. So this was the question. A beta 2 microglobulin will be having deposited, and this will be the reason for carpal tunnel syndrome, as I have told you. Right. Heredofamilial, it's a big family, and there are some disorders which I wanted to tell you, which is very commonly asked in exam. Right. So now you understand. So first, before I move on to the next slide, I would like to sum it up. Right. Primary is AL type. L stands for light chain, seen in multiple myeloma. Secondary is AA type, chronic inflammation, paraneoplastic syndrome. Most common chronic inflammation, rheumatoid arthritis, and remember renal cell carcinoma is associated with secondary type of amyloidosis. Hemodialysis associated amyloidosis is A beta 2 microglobulin. Usually they will be deposited into the synovium and joints and leading to the carpal tunnel syndrome when they are involving the hand and compressing the median nerve. Right. Now the fourth one, the heredofamilial type. Heredofamilial type, we are having three entities: familial Mediterranean fever, familial amyloidotic polyneuropathy, and senile systemic amyloidosis. Right. So these are the three types of the heredofamilial. Familial Mediterranean fever, you will be having serum amyloid associated amyloid, SAA type of amyloid. Familial amyloidotic polyneuropathy will be having mutant type of transthyretin, that is the mutant TTR. If you remember, this was the one of the option I have given, right? So mutant transthyretin, right? So that is the mutant transthyretin we are going to see here in familial amyloidotic polyneuropathy. Monica, you can see vaccine. I have kept one separate video. It's lecture going on, so we cannot deviate from the main topic. Senile systemic amyloidosis, also called as senile cardiac amyloidosis. And in this patient, what we are going to observe, in this patient, you are going to see wild type of, remember wild type means non-mutant. Remember, this was the question earlier in exam. So wild type means non-mutant. Wild type means non-mutant type of transthyretin. Right. So wild type or non-mutant type of transthyretin will be associated. So now you can see the two closer one which can create confusion in your exam. Mutant transthyretin is familial amyloidotic polyneuropathy, right? Senile systemic or cardiac amyloidosis is associated with wild type. Wild type means not mutant. Remember, wild type means non-mutant type of transthyretin seen in senile systemic amyloidosis. So these are the three heredofamilial. Familial Mediterranean fever, SAA type of amyloid. Amyloidotic polyneuropathy, mutant transthyretin. Senile systemic amyloidosis is the wild type of transthyretin, which is the non-mutant type of transthyretin. Clear? Right. Now moving on to the next one, localized type of. So I said the amyloidosis two types, systemic and localized. So systemic we have finished. In localized, A beta, A cal, PRP, SC, and AIPP. So now you tell me one by one. I'm asking questions to all of you. I want to see who is giving me the first correct answer. A beta amyloid will be seen in which type of condition? Which type of condition you are going to see A beta amyloid deposition? Which disorder? Yes, very good. So first answer I have got from the Sri Nandan Dikshit and Pragya. Right, very good, Sri Nandan Dikshit and Pragya. It will be seen in Alzheimer's disease. Very nice, very good. Right. What about the cal? What is this cal stands for? This cal is the calcitonin. Can you tell me A cal or calcitonin will be present in which disorder? Very nice. Sri Nandan Dikshit, again he is telling the first answer. Pragya is again same. So it is for medullary carcinoma of thyroid. A cal is for medullary carcinoma of thyroid, right? So A cal is for medullary carcinoma of thyroid. Right. APRPSC. Can you tell me what is this? APRPSC. Very good. This time Shubham is telling the first correct answer. That is the prion disease. PRPSC is the abnormal prion disease. So this will be seen in the brain and seen in the brain of which disorder? Prion disease, right? So progressive dementia, yesterday also we have discussed, right? So now you can see that A beta is for Alzheimer, A calcitonin is for medullary carcinoma, APRPSC is for the prion disease, and AIAPP, islet associated polypeptide. Can you tell me what will be the correct answer for this one? AIAPP. What will be the correct answer for AIAPP? Anybody? Very good. So this will be seen in type 2 diabetes mellitus, not with type 1. So that was again a very hot topic for examiner. So AIAPP will be seen in type 2 diabetes mellitus, because type 2 diabetes mellitus, you are having pathology is insulin resistance. They are not having, yeah, na, they are having beta islet cell. The problem is insulin resistance is present, whereas in type 1 diabetes, beta islet cell will be having atrophy, and you know that amyloid is between the cell. If cell is not there, where they are going to deposit? So please remember this point. Type 1 diabetes, type 2 diabetes can be discriminated on the basis of amyloidosis also. Amyloidosis will be seen in type 2 diabetes, not in type 1, and that will be AIAPP type of amyloidosis, right? Done. So now we have cleared all these amyloid. Now moving on to the next question. A 70-year-old vegetarian male presented with the findings given in the image, most likely diagnosis will be. So now you can see the clinical finding, and there is an image of the peripheral smear. So can you tell me what should be the correct answer here? I want to see that who is giving me the first correct answer. Very nice. Abhijit 93, very good. Abhijit, Amit Chaturvedi, Pragya, Srinandan Dikshit, Shubham Sikdar, very nice. So all these people have given me the first correct answer. See, this question is a very simple question, came in NEET also and FMGE exam, both exam. See the history, beautiful history. Vegetarian male, vegetarian means these people will be having deficiency of vitamin B12. Yes, very good. Very good, right? So these are having vitamin B12 deficiency, because vegetarian will be having deficiency of the vitamin B12. And when you are going to see the finding, right, you can see in finding in the, dorsum of the hand, you can see on fingers, you can see darkness is there, and similar type of darkness you can notice here also. So what is this? These are all melanin pigmentation, hypermelaninosis. You can say that melanin is, yes, a melanin pigment will be more here. So that will be a history, a hint for megaloblastic anemia. And now in this peripheral smear, you can see 1, 2, 3, 4, 5, 6, and 7. So more than 5 nuclear lobes in the neutrophil, hypersegmented neutrophil, right? And if you see, this is the normal RBC. If you assume this is the normal RBC and you compare, this is the ovalocytosis. So hypersegmented neutrophil, ovalocytosis, and can you notice what is this? Howell-Jolly body. So Howell-Jolly body. So this is the characteristic triad of the megaloblastic anemia: hypersegmented neutrophil, macroovalocyte, and Howell-Jolly body. So this picture, clinical finding and peripheral smear finding, is correlating things together to the megaloblastic anemia. It cannot be iron deficiency anemia, right? Sickle cell anemia will be showing you sickle cells, and hereditary spherocytes will be showing you spherocytic appearance, right? So that is why answer should be A. So this is the case of megaloblastic anemia, vegetarian male, and these findings of the hyperpigmentation, right? So now we will see in detail. Always remember, as I said, these are the area, you can see, these are the area where you are noticing melanin pigment is there. Increased melanin pigment is there. You can see here also there is a increased melanin pigment. So these are usually associated with vitamin B12 deficiency, right? So here you can see that in any vitamin B12 deficiency, patchy hyperpigmentation of skin can be seen. And remember, 10% of the patient will be having reversible melanin skin pigmentation. Remember, these are reversible melanin skin pigmentation, and usually it will be affecting the knuckle pads or oral mucosa. So you can see knuckle pads or oral mucosa is having this kind of melanin deposition, right? And remember, this is the one of the under recognized sign, right? These are the under recognized sign which you see in megaloblastic anemia, and you must look for this sign if a patient is coming in this with the setting of the pallor. Remember, under recognized sign of megaloblastic anemia, and always to be looked for in the setting of the pallor, because when you are seeing the pallor, you may think or you may get confused with the iron deficiency anemia on clinical examination. So when you find this hypermelanosis or melanin deposition into the mucosa and the pad of the knuckles, so you should think of vitamin B12 deficiency. Take out the blood sample, make a peripheral smear, and think about it. So now you can see on peripheral smear, as I have told you, what we are watching, this is the hypersegmented neutrophil, right? Hypersegmented neutrophil. Now this one is the normal RBC. So if you compare this RBC, now you can see what are these RBC. These are all showing macroovalocytosis. And now here you can see there is a blue dot, and this blue dot is the Howell-Jolly bodies, right? So these are the characteristic triad of the megaloblastic anemia. So remember, what are the characteristic triad of megaloblastic anemia? Macrocytosis, hypersegmented neutrophil, where you will be seeing more than 5 nuclear lobes per neutrophil, and Howell-Jolly bodies. What is Howell-Jolly bodies made up of? That is again a very important MCQ. So they are nuclear remnant, so made up of DNA, right? So they are nuclear remnant, they are made up of DNA. So this is the Howell-Jolly bodies. So now you understand, macroovalocytosis means MCV is more than 100 femtoliter. That is again a very important point to remember, right? So remnant of the nuclear membrane, so it is a vitamin B12 deficiency, right? So this is a Howell-Jolly body, right? So now you understand. So again, I will show you that picture which I have shown you earlier. You can see this is the hypersegmented neutrophil. Red mark, red arrow is the hypersegmented. Black arrow you can see here, these are all macroovalocytosis, MCV more than 100 femtoliter, and now this green one is the Howell-Jolly body. I have just kept teardrop RBC. There is no significance here because it is not a very significant thing, right? In this case, just one significance, it is showing that bone marrow is not having proper maturation. The bone marrow has been compromised. So that is the meaning of this teardrop RBC, right? So there is a dyserythropoiesis. So Howell-Jolly bodies, they are made up of DNA, and they are also sign of bone marrow dyserythropoiesis, or you can say ineffective erythropoiesis. Ineffective erythropoiesis. So that is the important point about the vitamin B12 deficiency, right? Now coming to the next question. A 16-year-old boy presented with cervical lymph node enlargement and periodical fever. Lymph node biopsy was taken and histopathology is given below. So now you can see these are the two histopathological diagram. Beautiful picture. By seeing these histopathological diagram, you can come to the conclusion, right? Most likely diagnosis will be. So tell me, what will be the most likely diagnosis? Lymphocyte predominant Hodgkin's, or lymphocyte rich Hodgkin's lymphoma, nodular sclerosis Hodgkin's lymphoma, or lymphocyte depleted? So tell me. Yes, teardrop is non-specific. It can be seen in myelodysplastic syndrome, where bone marrow maturation is affected. Yeah. First correct answer is given by Nitesh and Pragya. Right, Nitesh and Pragya has given me the first correct answer. That is the, see, what we are observing. 16-year-old boy, cervical lymph node, right? Periodical fever. So Pell-Epstein fever. You remember Pell-Epstein fever, 15 days fever, 15 days no fever, 15 days fever, 15 days no fever. So that is called periodical fever, which you see in the Hodgkin's lymphoma. So what is this? That is called Pell-Epstein fever. So this periodical fever is Pell-Epstein fever, which you see in case of Hodgkin's lymphoma, right? So in this patient, what we have done, we have taken the biopsy, right? We have taken the biopsy of the cervical lymph node, and in the biopsy you can notice what we are noticing. There is a eosinophilic band. So now you can see this is the eosinophilic collagen band, right? So these are the eosinophilic collagen bands, right? And these bands are forming nodule. If you see carefully, You can see there are nodules, 1 nodule, 2 nodule, 3 nodule, 4 nodule, right? And this is all because of the collagen band. You can see it is running through it. These are all eosinophilic collagen band which are running through it. So collagen bands are forming the nodule. So you can see that in this picture, collagen bands are forming the nodule, right? So that is why this is called as nodular. Collagen band deposition is called sclerosis. That is why it is called as nodular sclerosis, right? Nodular sclerosis, because collagen bands are forming nodule, and in within this nodule, if you observe, cells are looking very clear. Cells are looking clear because during the paraffin section preparation, nodular sclerosis type of Hodgkin's lymphoma, cytoplasm will be removed, and now you can see this is how cytoplasm will be looking like. This is how cytoplasm will be looking like. So because of this lacuna, because of the lacuna has been created into the cytoplasm, so such type of cells are called as lacunar Reed-Sternberg cell. So these are lacunar Reed-Sternberg cells which are seen in nodular sclerosis type of Hodgkin's lymphoma. Clear? So this is the lacunar, yes, very good, Srinandan. This is the lacunar Reed-Sternberg cell which we are seeing in this condition, right? So this is the right answer is nodular sclerosis. Lymphocyte predominant, can you tell me what kind of Reed-Sternberg cell you are going to see? I will discuss, right? Popcorn Reed-Sternberg cell. Lymphocyte predominant will be having popcorn Reed-Sternberg cells. Lymphocyte rich will be having mononuclear Reed-Sternberg cell. They will be having mononuclear Reed-Sternberg cell, right? And lymphocyte depleted will be having mummified Reed-Sternberg cell, right? So these are the important point about the Reed-Sternberg cell. And in this picture, examiner has given you nodular sclerosis, nodules formed by the collagen, and they are containing lacunar Reed-Sternberg cells. So I am going to give you a little bit detail about the Hodgkin's lymphoma. Brief discussion, not very much high-fi. Hodgkin's lymphoma as per WHO classification. We are following WHO classification at present, right? And WHO classification says that Hodgkin's lymphoma should be divided into two parts, right? Classical and non-classical. Non-classical is also called as nodular lymphocytic predominant Hodgkin's lymphoma, or simply it is also called as lymphocyte predominant Hodgkin's lymphoma. Nodular lymphocyte predominant Hodgkin's lymphoma, or simply we can call this as a lymphocyte predominant Hodgkin's lymphoma. So what I want to tell you here, that immunophenotyping of Reed-Sternberg cell is the basic reason for the differentiation between classical and non-classical Hodgkin's lymphoma. So Reed-Sternberg cell, when you are going to see classical, they will be positive for 15 and CD30. So CD15 and CD30 marker will be positive for the classical Reed-Sternberg cell. But in case of the nodular lymphocytic predominant Hodgkin's lymphoma, where you are going to see popcorn Reed-Sternberg cell. Please remember, one of the very favorite of the examiner right now, right? Examiner, they ask this question. And in these patient, when you are going to look into the CD markers, they are 15 and 30 both negative, right? So what is the correct thing for the nodular lymphocyte? They arise from the germinal center, right? They arise from the germinal center, and that is why they will be positive for CD20, 45 and BCL6. So these are the marker of the non-classical or nodular lymphocyte predominant Hodgkin's lymphoma. So you can see in this other picture also, right? Nodular lymphocytic predominant will be usually young patient. And another very important point, usually Hodgkin's lymphoma is associated with Epstein-Barr virus infection, but nodular lymphocytic predominant is having no association with Epstein-Barr virus. That was the question in the exam. So it is not associated with Epstein-Barr virus infection, not associated with Epstein-Barr virus infection, since they are arising from the germinal center, 20 positive, 45 positive, and BCL6 positive. But remember, classical 1530 will be negative, and they will have best prognosis, right? They will be having best prognosis amongst the all type of Hodgkin's lymphoma. Now, classical Hodgkin's lymphoma, there are four types: nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte poor, right? Now I am going to show you about the nodular sclerosis, which was the question. As I have told you, collagen band. Collagen bands means sclerosis. Remember, sclerosis means collagen band. So collagen bands are formed right? And these collagen bands are forming the nodule. So now you can see there are two nodules. There are two nodules formed by collagen band. So that is why it is called as nodular sclerosis. Nodular sclerosis. That is why this name has been given. And when we are preparing this paraffin section, right? When we are preparing this paraffin section, what we are going to see that there will be a clear cytoplasm. Cytoplasm will be removed, right? This is the artifact. Cytoplasm will be removed, lacuna will be created, and that is why such cells are called as lacunar Reed-Sternberg cell. Right, so nodular sclerosis is a classical Hodgkin's lymphoma, right? So if examiner asks you, lacunar Reed-Sternberg cells will be positive for which marker? Which CD marker? 20 positive or 15 positive? What should be your answer? Anybody? Lacunar Reed-Sternberg cells. So tell me, what should be the positive? Yes, CD15 positive, because these are classical, na? CD15, CD30, both will be positive. CD15, CD30, both will be positive in the lacunar type of Reed-Sternberg cell, right? Now, this is the picture. As I have told you, there are eosinophilic collagen bands. So these are the eosinophilic collagen bands, right? So these eosinophilic collagen bands are creating the nodules. Already I have shown you, these are the nodules, you can see. So eosinophilic collagen bands are creating nodules. That is why this Hodgkin's lymphoma is called as nodular sclerosis, right? Nodules are created by collagen bands, nodular sclerosis. And when you are going to examine on high power view, see, this is the low power view of the lymph node biopsy, and this will be high power view of the lymph node biopsy, where you can see there are cell, and this is the clear lacuna. There is no cytoplasm. So these cells are called as lacunar Reed-Sternberg cells. So these are called as lacunar Reed-Sternberg cells, and this will be seen in nodular sclerosis Hodgkin's lymphoma, right? Now, this is the another beautiful picture where you can see I am showing you a cell. Can you notice this cell? This is the cell. This is the Reed-Sternberg cell. But contrary to the classical Reed-Sternberg cell, you can notice only one nucleus is present. So this is called mononuclear Reed-Sternberg cell. Mononuclear Reed-Sternberg cells, right? So mononuclear Reed-Sternberg cells, where you are going to see mononuclear Reed-Sternberg cells, you are going to see in both lymphocyte rich and mixed cellularity. Please remember this point. It's a very, very important point, because we often do not study about this. Mononuclear Reed-Sternberg cells are seen in the mixed cellularity also. Mixed cellularity of the Hodgkin's lymphoma, and this will be also seen in lymphocyte rich variant of Hodgkin's lymphoma. So both will be having mononuclear Reed-Sternberg cells. So this is the little bit away from the classical owl eye appearance containing classical Reed-Sternberg cell, right? Now coming to the next one. In this, you can notice there are two centrally located Reed-Sternberg cell. If you look at them, you will find that they are having a dark staining eosinophilic cytoplasm. So you can see there is a darkly eosinophilic cytoplasm. So darkly eosinophilic cytoplasm, and there is a very pycnotic nuclei. Pycnotic means very compressed. Chromatin is condensed. So what is this? This is called as mummified Reed-Sternberg cell. Remember, this is the name of mummified. So this is not given in the Robbins also, right? So please remember, examiner asked all these questions. Mummified Reed-Sternberg cells are seen in lymphocyte poor Hodgkin's lymphoma. So remember, this will be seen in lymphocyte poor Hodgkin's lymphoma. So that is the important point you have to remember, right? So lymphocyte poor or lymphocyte depleted, both are same, right? So they will be having mummified Reed-Sternberg cell. Now coming to the lymphocyte predominant, right? Predominant will be having popcorn Reed-Sternberg cell. And remember, the actual name of popcorn Reed-Sternberg cell is LH variant of Reed-Sternberg cells. right? So also known as popcorn Reed-Sternberg cell. So how you are going to identify popcorn Reed-Sternberg cell during exam time? So that time you have to remember a few things. You are going to identify popcorn Reed-Sternberg cell along the feature of the nucleus. So nuclear features are going to help you to diagnose this popcorn Reed-Sternberg cell. What will be the nuclear feature? Can you see? There is a polyp-like polypoidal nuclear lobe. Right? We'll be having polypoidal nuclear lobes. So either it is a polypoidal nuclear lobes or it may be a syncytium-like or multilobated appearance of the multilobated appearance of the nuclei. So now you can see nucleus is having two kind of appearance for diagnosis of the popcorn Reed-Sternberg cell. Either they should have a polygonal nuclear lobes, polypoidal nuclear lobes, or they should have a multilobated nuclear lobes. So this will be seen in the popcorn Reed-Sternberg cell, right? So this will be seen in popcorn. I am not actually associated with the clinical hematology, right? Treatment will be better, explained by clinical hematologists. Right. Either clinical hematology or the medicine. Maybe I will be trying after some time, right? I will be definitely trying for the medicine if you have asked me, but not with the immediate effect, right? So I really apologize for that thing. Right. So now you can see this is the picture of the popcorn Reed-Sternberg cell. It's easy to identify. Just you have to focus. What you have to focus. Now you can see there are a few things I am going to demonstrate. Now you can see this is the cytoplasm. Just focus on these three Reed-Sternberg cell which I wanted to show you. Now look into the nuclei. Look into the nuclei. Can you see the nuclear lobes are hanging like a polypoidal nuclear lobe? This is the multilobated nuclear lobe. You can see multilobated nuclear lobe, right? This is again multilobated nuclear lobe. So when you see multilobated or polypoidal nuclear lobe, so that means it is a popcorn Reed-Sternberg cell. So this is the popcorn Reed-Sternberg cell, and whenever you find popcorn Reed-Sternberg cell, that means it is a lymphocyte predominant Hodgkin's lymphoma, which will be 20 positive, 15 negative, 30 negative, and BCL6 is positive because they are the marker of the germinal center. So is it all clear? No, it is not BCL2, it is BCL6. Please remember, BCL2 is anti-apoptotic seen in follicular lymphoma. BCL2 will be seen in follicular lymphoma. It is a BCL6. Remember, here I will tell you there are few cancers which are BCL6 positive and you should remember. Right? These are the two cancers which are BCL6 positive which you should remember. Number one, we are discussing lymphocyte predominant Hodgkin's lymphoma. So can you tell me what is the second number where African baby will be affected and they will be having the mass in the mandible? Anybody? Where you are going to see the BCL6 positivity in which other leukemia lymphoma? Which other leukemia lymphoma BCL6 will be positive? Yes, very good. Pragya is telling Burkitt's lymphoma. So this will be Burkitt's lymphoma. So Burkitt's lymphoma will be positive. Burkitt's lymphoma will be positive for the BCL6. So please remember BCL6 is a marker of germinal center, positive for lymphocyte predominant and Burkitt lymphoma. So I think this question is done. Now coming to the next question. All are true about Lyon's hypothesis. Lyon's hypothesis. So that is again a very important question. Lyon's hypothesis, which is not correct. Only one of the X chromosome is genetically active, or only one X chromosome undergoes pycnosis, or inactivation occurs on 5th day of the embryonic life. Gene exist causes gene silencing. Only X chromosome from the mother undergoes pycnosis. Inactivation occurs on 5th day of the embryonic life, or gene exist causes gene silencing. What should be the correct answer for this question? Because if you are saying C, in guidebook it is given wrongly. If you read the Robbins, you will find that inactivation occurs on day 5 only. So who is giving me the first correct answer? Prabhu Srinandan Dikshit has given me the first correct answer. Answer is B. See, what Lyon's hypothesis says that only one of the X chromosome is genetically active. So that is a true statement, right? There are two X chromosome in female. One of the X is genetically active and one is dormant or inactive, right? So first statement, if I start analyzing, I will tell that first statement is a true statement. Second statement, only X chromosome from mother undergoes pycnosis. Pycnosis means condensation. So tell me, B is true or false? So B is a false statement because it can be anyone. It can be father's chromosome also. It can be mother's chromosome also. So any of the parents' X chromosome can undergo pycnosis. Please remember, only X chromosome from the mother undergoes pycnosis. That is the false statement. See what I am showing you. Suppose these are the two X chromosome. This is derived from the mother and this is from the father. So who will be having pycnosis or inactivation? Right, so remember, any of them can have inactivation, any of them, right, any of them can have inactivation, right. So now you understand, inactivation occurs on fifth day, blastocyst stage of the embryonic life, which is on fifth 5.5 day of the embryonic life it will be happening. So that is a true statement, that is the true statement. Gene cyst causes gene silencing, so that is the again a true statement. So which is a false statement? B is the correct answer. So now you understand, X chromosome from the any of the parent can be inactivated. Now I am going to explain this Lange hypothesis because that is very important for exam and many times it has been asked. So what Lange hypothesis says, there are four hypotheses. See, I am showing you two X chromosome and only one X chromosome will be inactive. Number one point. So now you understand, this is active, this is inactive. So only one X chromosome of the mother's X is inactive. Right, now you can see I for inactive. So who will be inactive? Either maternal or paternal. So any of them can be inactivated. So now you got this question. What was the what was the point? That this X chromosome is inactivated only from the mother. That was the wrong statement. Inactivation can happen to any of the X chromosome. It can be maternal origin also, it can be paternal origin also. Right, so maternal, paternal, anybody can be inactivated in this Lange hypothesis. And this inactivation of the X chromosome occurs at the blastocyst stage on day 5.5 of the embryonic life. This is the line of Robbins. Many guidebook I have seen, they have given wrongly. They have given 16 days or something. That is wrong thing. Please correct that thing. Right, so it is 5.5 day of the embryonic life where you are going to see this one X chromosome is going to get inactivated. And the X chromosome, see this, the X chromosome which has been inactivated, whether it is a paternal or maternal, whatsoever has been inactivated, same will be inactive in derived cell also. Same will be inactivated in the derived cell. So now you can see this is the X chromosome, right? There are two X chromosome, one is blue and one is red. Suppose blue has been inactivated here. So in the next progeny, only blue will be inactivated. That is the meaning of same will be inactivated in the derived cell. Right, now you can see, if you see red one is inactivated, so same red is inactivated in the upcoming progeny or upcoming derived cell. So that is what it says, that same X chromosome will be inactivated in the derived cell. Here it is blue color chromosome and here it is red color. So same chromosome will be inactivated in the derived cell. So that is the meaning of this statement. So now you understand Lange hypothesis, only one is X is active and inactivation can happen in any of them, maternal or paternal. Inactivation will happen at the blastocyst stage on day 5.5 and same type of chromosome which has been inactivated will be going into the derived cell, right? Right, so it will be recorded. This is live lecture. This will be recorded after some time. So now you can see what is bar body or X chromatin. Remember, this is the thing which I am going to explain because many of you are asking question regarding this. Bar body or X chromatin. Right, so bar body or X chromatin is a inactive X chromosome in female somatic cells only. Remember, it is female somatic cells only. That was the question in the NEET PG exam. Right, so now you understand. So female somatic cells will be having this bar body. So what is bar body? These are inactive X chromosome present in female somatic cells only. Right, so how we are going to identify bar body? Can you see, this is the cell membrane and this is the nuclear membrane, right? And bar bodies are inactive X chromosome, you can see here along the nuclear membrane. So they are darkly stained, they are attached to the nuclear membrane, and this will be seen at interphase nuclei, right? This will be interphase nuclei, right? So now you can see this is the interphase nuclei where you are going to See, Prader-Willi Angelman syndrome, you can see in my YouTube, there is a genomic imprinting topic that is recorded lecture. You can see beautifully explained for 45 minutes. You will understand each and every point very precisely, Ramakrishnan. Just see in my YouTube, you go and there is a series of the lectures uploaded. You can go through the genomic imprinting topic, genomic imprinting. Right? So now you can see darkly stained attached to the nuclear membrane. Can you notice how is the bar body appearance? They are darkly stained, dark blue color. They are attached to the nuclear membrane, and this will be visible under interface nuclei. Right. Now I want to ask you, what is the molecular mechanism of the bar body formation? Why bar body will be formed? That can be the another question from the Robbins, right? So bar bodies are formed because of the ZIST gene. You remember the fourth option I have given. ZIST gene is the reason for the bar body. What they will do? ZIST gene is controlling the formation of the long non-coding RNA. Remember, long non-coding RNA. This will be retained inside the nucleus. Long non-coding RNA is a gene silencing RNA. This is a gene silencing RNA, and this gene silencing RNA is going to inactivate X chromosome, right? They are going to inactivate X chromosome, right? So gene silencing will be done by X chromosome. Bar bodies we can see by simple Giemsa stain or Romanovsky stain. Right, Giemsa stain or Romanovsky. Simply we will be making a peripheral smear. You can see this is the peripheral smear, or this is the cytological smear, where you can see the bar bodies in the female cell, right? Male you are not going to see. In female you are going to see bar bodies, and this is the Giemsa stain, right? So Giemsa stain, or even in Romanovsky stain also we can identify, right? So can you see gene silencing of the X chromosome? So ZIST gene controls the formation of the long non-coding RNA, which will be retained inside the nucleus. And inside the nucleus, what they are going to do? They are going to cause inactivation of the X chromosome, and this will be looked as a bar body. So now in this picture also you can see, in this smear you can see this is the bar bodies. In female only you are going to see. In male there is no bar body. You can see there is no bar bodies in case of male, right? So what is bar body? Bar body is inactivated X chromosome, right? So now you can see bar bodies are inactivated X chromosome in females. Now look at this picture and look at this picture. These are the two puzzles you have to see, right? In this you can see there is no bar body. Nucleus is showing no bar body. Cytoplasm is clean. So always remember how you will count bar bodies. What is the formula of counting bar bodies, right? So formula of counting bar bodies is n-1. Remember, n-1, where n is the total number of the X chromosome, right? So now you tell me, in normal male, which is having XY chromosome, how many bar bodies will be present? Can you tell me? Normal male, how many bar bodies you are going to see? Comment box. Can you tell me, normal male, how many bar bodies you are going to see? X-1, so it will be 0. That's great. That will be great. So 0. And in Turner syndrome, n-1, and n is the number of X chromosome. How many X chromosome? 1. 1 minus 1, again here also 0. So what I wanted to show you, this number 1 is a pictorial representation of the normal male and Turner female. Turner female will be having no bar body. Please remember this point, right? So Turner female will be having no bar bodies, right? But when we are going to see a normal female, right? Normal female is having double X chromosome, right? Double X chromosome. So how many bar bodies will be present here? 2 minus 1 equal to 1 bar body, right? So you can see 1 bar body is visible. So this can be the normal female, right? This can be normal female. And remember, Klinefelter syndrome, somebody had asked this question. Klinefelter is having XXY. So XXY kind of karyotypic expression when you are going to see. So number of bar body will be again 2 minus 1, because there are 2 X chromosome. So 2 minus 1 equal to 1. So now you understand, normal female, Klinefelter syndrome, both will be having one number of the bar bodies. Is it clear to all of you how to calculate bar bodies? Bar bodies can be calculated by n-1. N is number of X chromosome, total number of X chromosome. So normal male and Turner syndrome is having only 1 X chromosome. So 1 minus 1 is 0, 0 bar bodies, right? Normal female 2 X chromosome, Klinefelter 2 X chromosome. So number of bar bodies 2 minus 1 equal to 1, right? So clear? So everybody understood bar bodies are formed by exist and long non-coding RNA, and bar bodies are also known as inactive chromatin or X chromatin seen in the female somatic cells only. Right? So done. Now coming to the next question. A patient came to the emergency room with the fever and headache. On examination, he was having neck stiffness. CSF analysis was showing increased opening pressure, mild increase in the protein content, normal glucose, and increase in lymphocyte count. Most likely diagnosis will be. So, what will be your most likely diagnosis of this CSF analysis? Anybody? Yes. Yes, very good. Who is giving me the first correct answer? Abhijit, Pragya, Sri Nandan Dikshit. Pragya has given me the first correct answer. Along with them, I think Abhijit also has given me. So very good. If you look at this history, right? So meningitis history has been given here, and you can see fever, headache, meningitis history, neck stiffness, CSF analysis, increased opening pressure, and protein has been increased. See, what is important to notice here, that protein level is increased and glucose level is normal. So glucose is normal will be ruling out all the bacterial infection, because in all bacterial meningitis, remember, there will be severe reduction of the glucose because they all require glucose for their metabolism. So please remember, this is a very important thing. So whenever you find this kind of meningitis feature, so bacterial meningitis will be having decrease in the glucose content, right? So that is why this cannot be a bacterial meningitis. So what will be this? This will be the viral. So Coxsackie is the virus. Coxsackie meningitis. Right. So this will be a viral meningitis, which is a Coxsackie meningitis. So this is the correct answer. Right. B is the correct answer. So I will just explain you this CSF analysis in a brief manner. This is the last question. So now you can see CSF examination. First, I will tell you the normal finding. Right. There are 6 parameters which we should know that. Gross finding, CSF pressure, cells, proteins, glucose and chloride level. Right. Now I am going to show you gross finding. Normally it will be clear and colorless. CSF pressure is normally 60 to 150. Remember, 60 to 150 millimeter of water, not mercury. Cells. Normally, will you find any cell in the CSF? Normally, when will you find any cell in the CSF? So answer is yes. Which cell? Lymphocyte. How much? 0 to 5. So normally 0 to 5 lymphocytes per micron liter will be present in the normal CSF. Right? Protein and glucose. These are the, these are the 2 parameters which examiner asks very frequently in exam. So proteins are 15 to 40 milligram per deciliter, and glucose level is 50 to 80 milligram per deciliter. Chloride level is 116 to 122 milliequivalent per liter, right? So these are the important normal finding in the normal CSF examination. What you have to observe, that if you find a cell, protein content will be also increased. So whenever cell count is more, protein will be more, because cell is made up of protein. Now understand this point. Cell is made up of protein. So whenever cell count is more, protein count will be also increased, right? So now you can see in this condition, bacterial meningitis, TB meningitis and viral meningitis. When you are going to see the gross examination, bacterial meningitis, because bacteria is having so much of neutrophil. Can you see they are having neutrophil, and neutrophil will be forming the pus. So that way they will be giving you a yellow straw colored or cloudy purulent appearance of the CSF examination because of the neutrophil. So cloudy or purulent. Now you can see correlate. You can correlate. Neutrophil is more, so it will be cloudy or purulent or pus-like appearance. Not pus, but pus-like appearance of the CSF will be suggestive of bacterial meningitis. Right. TB meningitis, there is a cobweb coagulum. Cobweb coagulum is a spider web. So why there is a cobweb coagulum? Anybody? Why there is a cobweb coagulum in the TB meningitis CSF examination? Anybody in the comment box? Because of the fibrin formation, right? Because of the fibrin formation, who is going to form the clot? This, remember, this cobweb coagulum is due to the clot formation within the bottle of the CSF, right? So there is a clot formation, and this clot is because of the fibrin. So remember, cobweb coagulum is due to fibrin, right? That is the important MCQ which examiner asks, right? Cobweb coagulum is seen in TB meningitis, and this is because of fibrin formation. Viral meningitis will be having clear, appearance. Sometimes they will be having, hemorrhagic fluid because of the tapping, right? And if you see, because of the fibrin, because fibrin is forming the clot, so that is why CSF pressure will be maximum. CSF pressure will be having maximum elevation in case of the TB meningitis, right? After TB meningitis, it will be increased in viral meningitis, and then it will be increased in the bacterial meningitis. So bacterial meningitis will be having lowest increase in the CSF, right? Maximum increase in CSF will be seen in TB meningitis. That is another important point, and that is all because of the fibrin clot is obstructing the lumen. That is why CSF pressure will be maximum here, right? On examination of the cell, they are made up of neutrophil in bacterial meningitis. TB meningitis and viral meningitis both will be having lymphocytosis. But remember, lymphocytosis will be more in TB meningitis in comparison to the viral meningitis. Clear? Now, if you look at the protein, because cell count is more, so protein is increased, protein is increased, protein is increased. So all will be having increase in protein because all are having increase in the cell count. So this is called association, right? Because cells are more, so protein level will be also more, right? Glucose level, because bacteria, they love glucose, they require glucose as their substrate. So there will be a severe reduction of the glucose in the bacteria. Mild reduction of the glucose in case of TB meningitis, and this will remain normal in case of viral meningitis. So viral meningitis, so now you understand. So when you see the protein and glucose, these two parameter on CSF examination, and you find normal CSF glucose along with increased protein, so that means it is a viral meningitis, and in this case it was Coxsackie virus meningitis, right? And chloride level, you can see chloride level is mild decrease in case of bacterial meningitis. That is another important point you have to remember. There is a mild decrease in case of bacterial, but there will be a severe reduction in case of the TB meningitis, and normal it will be in case of the viral meningitis, right? So now you understand. So this question is about viral meningitis. Now I want to tell you another potential question which examiner asked, that is called albuminocytologic dissociation. Now you understand what is albuminocytologic dissociation. Usually, you remember what I have told you just now. Usually proteins are elevated because of the cell count increase. Now you understand. Just now in CSF we have seen that there is the increase in the cell count, and because of the increase in the cell count, there is an increase in the protein content, right? So cell count is increased, so protein content is increased. But there are certain situations where cell count is normal. Can you see? Cell count is normal, cell count is increased, then only protein will be increased. But cell count is normal, but protein is level is high. So increased protein with normal cell count is not an association, it is a dissociation. Now you understand. This is the dissociation. So increased protein and cell count is normal. So this is dissociation called as albuminocytologic dissociation, which you are going to see in which condition? Guillain-Barré syndrome, intracranial neoplasia, and late stage of polio. So these are the three conditions. And out of these three, very frequently asked question is about Guillain-Barré syndrome, right? So Guillain-Barré syndrome is most commonly associated with albuminocytologic dissociation, which means protein is high but cell count is normal, right? So everybody understood this point. So this is the basic reason for albuminocytological dissociation, right? That cell count is normal but protein count is increased. So thank you so much. Now you know that diagnosis is viral meningitis. So answer is viral meningitis. So if you want to see my entire lecture, you can subscribe my app, that is the idpma.co.in. Here you are going to see more than 96 hours of the lecture with updates. And consistently, FMGE exam also more than 40 question is coming from this app, and I have seen previous year also and this year also, right? And I'm going to see again, right? And if you want to subscribe my book, you can go through the devaanshpublications.com and you can subscribe. The most important thing is subscribe my YouTube channel. I'm going to conduct many live lecture here, and you can get benefit from here. Definitely the topic I have discussed here, these are all hot topic for FMG exam especially, and you are going to get many question in your FMG exam from these discussion, not only the MCQs, from the discussion also you are going to get whatever I have taught you. This PDF will be available in the Telegram group, which is my Telegram group. I will be posting the link of Telegram group in my comment box also. So thank you so much. Definitely, I will plan for USMLE also. So don't worry. Thank you so much to all of you and for enjoying this lecture and interacting so nicely, right? And definitely, it is going to help you a lot. And remember, stay positive in these time, right? Because there are so many negativities around us. Please ignore everything. Om Ignorai Namah. This mantra you have to remember, right? Om Ignorai Namah. And ignore each and everything, whatever is going on, except for your studies. Focus on your studies, focus on your examination. Do not think about the result. Do not think about after the sequelae. Because what happens when you think more about the result, what will happen after the result if I do not get qualified? Then what will happen? You will start feeling sad about yourself. So why to think about that thing? Why to think negative, right? So think positive. Don't get gloomy feeling or depressive feeling that what will happen if I do not get. Don't think all these things. I am going to write exam. I am going to give my best performance. This should be your thinking. I am going to write exam and I'm going to give my best performance. Go with this thought process. You will never fail. And remember, failure is not a stigma. Don't think that you got fail and now your life is ruined. It's nothing like that. Failure is a lesson which will give you more, more power to learn and more power to, modify yourself as a successful person. You can see all the big successful people, they are the failures. They're not the, I'm not saying all are, but mostly they are failures, right? They are all failures and they have learned from their failures. They're not like they're poor. They have learned from the failures, because we are all human beings. We are all prone to commit error and to have a failure in our life. So don't worry about all those things. Give your best and everything will happen good for you. Thank you so much. Good night and best wishes to